morning, everybody. Sorry, good morning, everybody. To begin with, I would like to thank organizers, my seniors, colleagues, everybody, particularly Girish sir was here. I think he's not there, he's outside. And CPS as well as IAP Paediatrics for giving me this opportunity to go ahead with this panel discussion. So when they told me that we had to discuss about pediatric surgical problems in day-to-day life of the pediatrics, it's really tricky to discuss in front of all pediatricians about what are the different suture materials or laparoscopy or ports or something. So it is really tricky topic when to discuss. The whole intention of this topic is to identify the patients which are to be referred to the pediatric surgeon or involve the pediatric surgeon as early as possible. So I hope at the end of this my panel discussion, all of you should at least come to know that when to involve pediatric surgeons. There is nothing very different what I'm going to talk or we are going to discuss here. And also I'd like to reinforce that whatever pediatric surgeons do, it's a kind of a teamwork. Without the help of the pediatricians and particularly nowadays neonatologists, it is impossible to treat these patients. So that's why even in the panel discussion we have Dr. Santosh, Sanjay sir is here, and of course Shivaji sir is here. So we'll start with some case scenarios. So case scenarios, I'll tell about the cases and everything, and our panelists will discuss and we'll have discussion. But here I'd like to get many questions from the audience also. I don't want audience to just listen to this talk. Please ask the questions, because without your cooperation or questions, this cannot happen. So anyway, I'll start my topic. So common acute emergencies, we have just identified mainly in the pediatric. I have tried my best to avoid neonatology here apart from malrotation. So these are the day-to-day practice, what you see: acute appendicitis, incarcerated or obstructed hernia, testicular torsions, intussusception, pyloric stenosis, neonatal malrotation, or what we call the volvulus. And empyema also. By far and large, empyema is not like an emergency, but you can label it as a semi-emergency. Because recently in last 10 years, we are doing a lot of cases of VATS, video-assisted thoracoscopic surgery. And particularly senior pediatricians may have seen too many lobectomies when they were doing residencies. But now the number of lobectomies have come down, and mainly because of our early identification, intervention. So we are saving many lungs and lobes. So that is one reason I have included this particular topic here. So first case scenario we'll mainly discuss with Dr. Sanjay. So this is a 9-year-old boy who came with the abdominal pain, vomiting, and fever for last 2 days. Pain to begin with is in the umbilicus, later on shifted to the right iliac region, no other issues. When we examine this, there is a classical rebound tenderness in the right iliac region. So Sanjay sir, what we are looking at here?
And dear colleagues, in this scenario, I would like to entertain the differential diagnosis. First and foremost, I would like to give a diagnosis of acute appendicitis. Secondly, a Meckel's may present like this. Sometimes mesenteric lymphadenopathy. In the female, you could suspect TO mass also. And sometimes right side idiopathic colic. You should entertain that.
So based on history, is there any point where you can focus that this is more likely to be acute appendicitis and not a mesenteric lymphadenopathy?
More likely this is acute appendicitis because it is very common in children nowadays because of the habits of junk foods and all other dietary mishabits.
So mainly, if you look at the history also, there is a history of fever. So probably many pediatricians are seeing these patients who come with the abdominal pain. And if there is no history of fever, you should think about whether this is really acute appendicitis. This is more likely to be mesenteric lymphadenopathy or problems which are related to the motion, very rarely ureteric colic, Meckel's diverticulum. So how will you proceed, sir?
A routine blood investigation. The counts will be more, especially WBC counts. CRP will be high, more than 40, 50 in such cases of acute appendicitis. And as already know, UAG is the diagnostic for these all cases of acute appendicitis. The diameter of the appendix should be more than 6 millimeter. Usually it is seen as a turgid edematous appendix also. And if in few doubtful cases, we can do a CT. In selected cases, CT is the gold standard, not as a routine.
Yes, I think as sir has rightly told, earlier, surgeon used to come, just palpate the abdomen and will tell, okay, this child needs surgery. But nowadays that scenario is gone. So for acute appendicitis, we need 3 parameters. So first is, of course, an examination by a surgeon or a pediatrician who get a rebound tenderness or tenderness. Apart from that, CBC is very important. So you rarely see appendicitis where the WBC count is less than 9,000. So whenever you have appendicitis, WBC count is more than 14,000, more likely to have perforation. When they are more larger than that, they will have more likely to have abscess also. So same thing is more important with the sonography. So when you send these children for sonography, you have to look at these aspects. So this is the picture you can see. This is a normal appendix here, but this is non-compressible. That means when they push the probe, it doesn't get compressed, and non-peristaltic. So there is no peristalsis in this. And as well as sometimes you can see the frank ficolids in them. So even as a pediatrician, sometimes you can take a look at these pictures and you can yourself see, okay, this is more likely to be acute appendicitis. There is no need to read the report also. And this is one more picture where there is a CT abdomen. So CT scan is the gold standard. Whenever you admit the children with suspected appendicitis, always try to send the BUN and creatinine so that in case we have to do the CT, we know that there is no kidney issues. Now, this is where the appendix you can see. This is large and can I get the other point?
Jamir, I would like to highlight one more point. Investigations are here, radiological investigation is to exclude our other diagnoses. Mostly pediatrician and pediatric surgeon should be more aware of the clinical findings. Just to rule out other diagnoses like ureteric stones or tumors in females, only in this case the investigations are helpful. Otherwise, clinicians should be very perfect with the diagnosis of all findings.
Yes, that's very true. The only thing here particularly, when we send these patients to the radiologist, the sonography is very, very observer dependent. So many radiologists may like to, miss it, and that in that case, the CT is the gold standard. Now, if you look at this CT, this is a muscle mass you can see here. Sorry, this pointer is not working very well. So this muscle mass is too much for this child. So this is one of the important factor what we have seen nowadays. Somebody who has been trained in US, we used to often see the children coming in the age of 16, 17. But now those children we can see same in India now. So most of these children are obese. They may be, junk eaters or something, and very less on the sports. And you can see the muscle mass is too much here for this age group. So Sanjay sir, what is the pathophysiology? What do you think the basic problem here is?
Usually there are 2 types of appendicitis. One is acute obstructive and secondly acute catarrhal one. Catarrhal, we can have a repeated or recurrent manifestation. But in acute obstructive appendicitis, there is obstruction of the lumen because of some fecolids in the form of the, as Jamir correctly said, there is the junk fooders who had got some undigested food particle which get obstructed at the lumen of the appendix. With the obstruction, there can be secretion and overgrowth of the bacteria. And because of the constant pressure over the appendix, there are high chances of perforation in cases of obstructive types of acute appendicitis. And these are the ideal cases for the emergency appendectomies.
Yes, sometimes these children come with a, like a colic kind of pain. So pain is kind of on and off. You can think about, this appendix being obstructed in the early stages with the, fecolic. And then later on, if the symptoms persist, then at that time fever and everything will start and the complications may happen. So yes, and as sir has again rightly pointed out, whenever you are counseling your children about this, junk food or eating more fiber diet is very, very important, not only for the old or, so even for children, we have to start this thing now. So how will you proceed further, sir, then?
Preoperative assessment, that is patient should be kept NBM, IV fluids, IV antibiotic, especially in mild cases, we can try ceftriaxone or Advant. In selected cases of complicated, we should shift to higher antibiotic like Pivza or Meropen. And there is no role of conservative treatment because the study did not suggest in our India, at least in our Latur or regional setup, conservative treatment may help because patients may come from a distant places. Patient is not very serious about the concerns about the findings of complications of the appendicitis. The surgery plays the main role in the treatment of appendicitis, as it can be open or laparoscopy. Nowadays, we are doing 99% cases of laparoscopic appendicitis, laparoscopic appendicectomy for the acute appendicitis, as well as for chronic, as well as perforated appendicitis also.
Yes, that is one thing, like many parents Google their symptoms or child symptoms and diagnosis. And the first question nowadays, can we avoid the surgery? So as sir had said, as of now in India, at least we don't have any double-blind randomized controlled trials where we can say, okay, this child needs a conservative treatment and this needs a surgery. As of now, we are offering surgery to all the children. Yes, of course, where there is a socialized medicine, if you go to UK, if you go to Austria, in all these countries, everything is beared by the government. Here, there are so many case reports which are coming where they are managing it conservatively also. But the patients do understand, the implications and the problems associated with it. In our setup, it is really tough to do that. And surgery, yes, laparoscopy is the gold standard nowadays. Even for the perforated appendix or there is an abscess, you should go ahead with the laparoscopy. It decreases so many issues and complications. So this is just a pictorial diagram how we do the laparoscopic appendectomy. And so what are the complications you are expecting normally?
Usually the complication may be perforation of appendix, there can be appendicular mass, or then can be appendicular abscess. Because of the perforations and all other things, there can be a dense adhesions of the bowel to each other, may present like a small bowel obstruction also. But nowadays, we should try the laparoscopic appendicectomy, because with the help of laparoscopy, we can suck out all the pus and infected fluid from the pouch of Douglas, subdiaphragmatic pouches, and therefore chances of adhesions because of pus is very less. And also, laparoscopy will help for the differential diagnosis in doubtful cases. Sometimes there can be a Meckel's, which may present like acute appendicitis also. We can tackle the Meckel at the same time. And for the other things, if the pediatrician is thinking of mesenteric lymphadenopathy, which is a very commoner sonography finding, if you have the sonography of abdominal pain, the radiologists usually give mesenteric lymphadenopathy. In such type of cases, we can take a lymph nodal biopsy also.
So yes, laparoscopic appendectomy has decreased the chance of infection very significantly. Overall, all the complications have come down. So better to do and go ahead with the laparoscopy. So now next, we'll go to the next case scenario again. So again, very common scenario where, you have a 2-month-old child or an infant who comes with this picture, mother is complaining that there is a massive swelling on the right side and it is not reducing. Child also has the pain, vomiting, and you can see mild distension of the abdomen is also there. On examination, there is a bilateral inguinal swelling, more on the right as compared to the left. And on the right side, it is irreducible. There is a severe tenderness. So, any one of can answer, how we'll proceed from here.
Firstly, I would like to admit the child, insert a cannula, give a NS bolus.
So what is your thought? What is going with this child? What is happening exactly?
He has landed up in obstructive hernia.
So it's an obstructed right inguinal hernia.
Obstructed right inguinal hernia. So admit NS bolus, calm the child with analgesic, and then firstly I will try to reduce without giving any sedations. If not possible, then I will give a sedation, one shot, and again I will try to reduce. If that is also not possible, I will take the patient immediately to the OT and do operative management of the patient.
If required, you will take the child to the operation theater, give anesthesia or the sedation, and then reduce it and operate at the same time.
Yes.
Okay. So generally, yes, this is what we are doing nowadays. Whenever there is obstruction, we try to reduce it manually. If possible, that's okay. Otherwise, give some sedation, try to reduce. If that's okay, otherwise take the child directly to the operation theater and then do that. So again, surgical aspect in this is again laparoscopy versus open. So here most of the people are doing open, but we do laparoscopic repair for this also nowadays. And the question is why to operate early? It's like, can we wait for more than 6 hours, 8 hours? So is it possible? Shall we wait for a longer time?
We can't wait for long hours because incarcerated hernia, which will progress very early, very shortly. That is only we have a period of 2 to 4 hours where incarcerated hernia will land up into strangulated hernia, and we may have to do then exploratory laparotomy, resection, anastomosis, and all the complications will be increased. So as early as possible intervention or reduction manually has to be done in these patients, or else patient will land up in major surgeries.
Yes, that is one more thing which had changed over the last 20 years. When I joined my residency way back in 2004, at that time, like we used to get many patients who need exploratory laparotomy for this, because they used to come late, there will be perforation of the bowel, or some part has become gangrenous. So all these complications can be prevented if we try to operate them early. And particularly here the word is important about the prematures or the neonates. So in the neonates or premature, this is more likely to happen. Their blood vessels are very, very small, so easily get obstructed or thrombosed, and the complication rate is actually more in them. So this is again same what we discussed about. Now just to tell you about, because as a pediatrician, probably one of the highest number of patients are seen by you as far as the hernia is concerned. So it may be difficult for you to talk to them also when to operate. Many children, many parents may not want to get it operated. So what do you think, Dr. Shivaji, the rate of incarceration or obstruction in normal inguinal hernias, depending on the age?
Depending upon the age group, sir, basically premature or neonatal age group, the percentage where incarceration will turn up into the strangulation is about 23%. Then comes to the infancy, first 1 month to 3 months or up to 6 months, the rate of incarceration to strangulation are very high. That will land up to 31%. And after that, it will gradually start declining, and the children older than 3 to 5 years will have very less number of strangulation issues.
Yes, so more the age, less is the likelihood of developing the obstruction. So first year of life is very, very important. Whenever you see the hernia or you are suspecting, involve the pediatric surgeon earliest in those patients, because those are the patients who needs pediatric surgery and intervention. So this is just a graph which is showing the same thing. This is showing the percentage on the left side and age on the downside. So you can see during the first 1 to 2 months of life, the chances of obstruction are very, very high. Some of the literature reports are up to 57%. So that's very, very high. And if you look at, as we, the age is more, the chances of obstruction, they go down. So early it is better. So now this is the third case. Actually, Dr. Ramdas was supposed to join us.
But hydrocele, I want to highlight one more point, Jamir. Firstly, pediatricians should be aware to differentiate between the hydrocele and hernia. Hydrocele, we can safely wait up to 2 years of life. But in a case of hernia, we should operate on day 1 also. I operated 2 to 3 cases on day 1 as obstructed inguinal hernia in a neonate. And one patient, we have to resect the sigmoid colon also, which was the content in these patients. Thank you.
Yes, that's one good point, sir, which has mentioned. So even now in Latur also we have many neonatology centers. So they may be getting more premature neonates. Now premature neonates are more likely to have this hernia. Now when to operate it? Now most of the places we should be more familiarized with the anesthetist or anesthesia which is available. So if anesthesia is okay, then we can operate these children even at the weight of 1.2 kgs. So in my institution, we follow the criteria before sending them home, operate. So this is the simple thing, and thank you, sir. Yes, that's a good point. So this is the third case. Actually, Dr. Ramdas was supposed to join us, but because of sickness, he could not. So any one of us will just discuss. So this is a 9-year-old boy who comes with a sudden pain in the right hemiscrotum. And this is there for last 6 to 8 hours. He has vomiting, there is no fever, there are no other urinary symptoms. So examination shows right hemiscrotum which is red and very tender. So just questions to all of you, what we are looking at here? What is the diagnosis? torsion? Why not acute epididyma architis? Yes, sir, that's a very good point. So practically, to be frank, like acute epididymal architis doesn't happen in children. There are no evidence which says that it will happen. But yes, that is commonly labeled by the radiologist. So that's why we go ahead with that diagnosis. So most of the time, whenever the child comes with these symptoms, first thing you have to think about is whether we are dealing with the torsion. Because your management, the time constraint is very less for this particular entity. So again, Shivaji sir, what do you think we should do? What is your diagnosis and how will you like to proceed here?
Yeah. First, I will examine the child clinically. We have to differentiate whether it is epididymal architis or a torsion.
Yes, clinically, as I said, it is not possible. So how will you proceed now?
Then I would like to immediately do a color Doppler, USG color Doppler of the scrotum, and see how is the blood flow and how is the testis, ecotexture of the testis.
So this patient comes to you in Latur. Patient has gone to some radiologist. Radiologist hasn't mentioned anything much about it. Now what will you do?
Rightly, means if USG is already done, then we have to explore the patient, look for the testes. If it is viable and after detesting everything is okay, then it's okay.
Yes, that's very good point, because what happens is that all this radiology is very, very observer dependent. So you have to think twice sometimes when you are strongly suspecting clinically, okay, this child has a torsion. So whether I should just, turn away that report and go ahead with my clinical acumen. So that is better, I think. But yes, some good radiologists can tell you about absent flow and decreased flow. Rarely, actually, there may be a little bit of hyper flow also in that particular thing. So ultimately, any doubt is there, best way is to open and see. That is what the surgeons love about. So, and there is something called as a golden hour. What do you think, Sanjay sir, what is the golden hour?
Acute scrotum is always a torsion of testis unless proved otherwise. Because if you have a negative aspiration even after the surgery, that's no doubt or no point or no problem. The golden period, as you asked me, is only for 4 to 6 hours. But when the patient comes to, it's already late. And when we refer to the radiologist for the sonography, there is a high queue over the centers. They will take more than 2 to 3 hours. Again, in the evening, patient will come late with have some feeds, and again, it will take no nearby mouth status, and ultimately, patient will go for exploration on the second day. This should not be happen in case of acute scrotum. Therefore, when you are doubt, you should ask personally to the radiologist to see torsion is there or not. Don't give him a diagnosis of acute epididymal architis.
Yes, that is very important thing. As a clinician, you should have numbers of some of your good radiologist friend or somebody, whether you can, when you can refer the child, talk to them. No, this is a priority. Do it early. Do not wait for more than 1 or 2 hours. This is not going to help the child. As I have mentioned here, time is testis. So if you, save the time, the child's testis will be saved. Otherwise, we are not going to do it well job. And there are so many reports which are coming from the Western world, and this particular which I have highlighted, they have a 25 years of experience and 558 patients. So they have categorically mentioned that, golden hour is actually 4 hours. So I know in constrained situations when there is a less availability, this is not feasible. And many of our patients, they may take themselves late. But whenever they come to you, involve the pediatric surgeon, involve the radiologist, try to be on top of it so that we can save the testis. So what is the ideal treatment, Sanjay sir?
Surgery is the main treatment for the torsion of testis. Explore the scrotum with a midline incision. Firstly, we should fix the normal side testis first to avoid torsion, because it is a congenital anomaly. May happen the torsion of normal testis in the future life. And we have to fix first opposite normal testis, because the inflammation from the infected testis should not go to the normal testis. First, we have to do normal side orchopexy. And secondly, when we explore the torsion of the testes, we have to see the viability of the testes. You have to detort it, wait for few minutes, 10, 15 minutes. Then we have to apply the hot fermentation, hot warm packs. And mostly, if the patient comes to 6 hours, we may definitely save. But now the theories are proved that we should keep and conserve as time already lapsed also. 8, 10, 12 hours, we should preserve the testes. Because at least some hormonal functions will be there in the case of torsion of a testes. And relatives should be called in the operation theatre to show all the findings first. And we should have a clinical photographs. That is very important in the medical legal aspect. And secondly, a close follow-up. If you save or conserve testes, close follow-up is very important.
Yes, as a surgeon, I'm more concerned whenever I conserve the patients. Because, they will have multiple questions, they will come in the follow-up, and I have to justify what I have done. So, this particular patient, I did not, do the orchidectomy. I just fixed the testes on both the sides. The child has come to me after 3 months for the follow-up. And as of now, at least the testes are looking okay. The size is same on both the sides. Blood flow is looking good. But even today, I don't know whether this will withstand in the long term. So long-term follow-up is very, very necessary in these children. And always explain to the parents what we have done. So this is the pathophysiology where, normally the testes look like this. This is the first picture, which is normal. And you can see it is becoming more horizontal in the second picture. So that this is called as a bell-clapper deformity. And when they have done the autopsy, this bell-clapper deformity was found in 12% of the normal individuals. So you can imagine how common this is. This is very, very common. And whenever there is a torsion, this is how it looks in the last picture. So we discussed about this follow-up already. Now, rarely the presentation can be variable. Recently, I had one child who was like 12 years old, extremely obese and a very, very shy child. So they have gone to one other hospital, got admitted, done all the workup for his abdominal pain, and they have discharged him saying there is nothing wrong. And when the child came to me, just for the routine examination, I touched his scrotum, and definitely there was a swelling. So as a pediatrician, you should also learn to, look at the inguinal regions as well as the, genitalia before completing your abdominal examination. Of course, we pediatric surgeons do it by default. So that's very important point one should know. In the infants, this presentation of the torsion is very, very different. They will just cry excessively and may have vomiting, distension of the abdomen may be there. So one has to be very careful when they are assessing you. Generally, this torsion happens either at the age of around 1 year of the life, or more commonly, they come around 12 years or 14 years when suddenly in the puberty, there is a massive secretion of the testosterone and the testes get torsed. So these rare presentations also you should be aware as a pediatrician. So again, we'll come back to Sanjay sir for this one. This is an infant, a 6-month-old with the excessive episodic cry, has a colic abdominal pain and non-bilious vomiting. So very, very common scenario. What we are dealing with it? Can anybody please answer? Okay, yes. So probably we are looking at that. So pain is intermittent. Child is listless in between the pain. In between the pain, he's again playful, he's active. And mother tells you something that, okay, there was little bit blood looking like stool. So, Sanjay sir, what we are looking at here?
Commonly, a differential diagnosis, pediatrician would like to entertain enterocolitis or diarrhea dysentery. But as a surgeon, I would like to diagnose it as an intussusception.
Yes,
it's very common nowadays, especially after the viral fever and viral URTI. Last week, I have reduced 3 cases of intussusception in a week only.
Yes, so, as a pediatrician, you should know about the incidence of this intussusception. So intussusception commonly happens between the age of 6 months to 2 years. That is the weaning period that may be related to the, current undergoing some kind of viral infections, mesenteric lymphadenopathy. So whenever a child in this age group comes with the abdominal pain, listlessness, and mother is telling you this history, always send them for sonography, just to make sure we are not missing. Just don't make it as a diagnosis of some kind of enteritis or gastritis and wait and watch. So this is the diaper which mother shows. So this is the classical, I think, red currant jelly. Sir, what is the reason for this red currant jelly? Why this happens?
This is because of the secretions of the goblet cell, that is the mucus, and red currant because of intestinal secretions and arrest of blood supply of the bowel. ideally we should not wait the red currant jelly should appear. I would like to advise and give suggestions to my junior colleagues, the pediatrician, when there is a doubt, when the patient have got abnormal symptom like abdominal pain or excessive cry, we should always do a sonography. Always, always, especially in the viral season. Because
Yes.
we can miss clinically a lump in the abdomen because patient's abdomen is very tight. When we seen in the OPD, you always have a OPD of more than 100 and 150 patients. Therefore, we can have a selected patient direct sonography.
Yes, many of our children may not, show those classical signs, like empty right iliac fossa or, palpable mass or something. And when the child is crying, very difficult to judge the abdomen also. So simple sonography is the best way. As the sonography, not only will pick it up intussusception, but sometimes it is not there, it will rule it out also. So that way then you are okay. As a pediatrician, you are, ready to deal something else which is there. So,
Secondly, Jamir, for the sonography to do, I always send the patient with traclofas with the maximum dose. Therefore, till the patient reaches to the radiologist colleague, patient will already be calm and he can examine very thoroughly.
yes, of course there will be always concern about giving something sedative, but if we can avoid that is better, but if it is not possible, then you should give it and send the child. So this is what we see. So Sanjay sir, what we are looking at here again? So what are the classical findings on the sonography?
A target sign, as you correctly mentioned, that is in case of ileocolic intussusception, we can see a color Doppler finding to show the viability of the intussusception and intussusceptum. There can be associated lymph node, which is the main cause, and sometimes appendix or Meckel's can be seen very rarely. These are the findings, and electrolytes and CBC should be performed, and patient should be hydrated as early as possible for the reduction.
Yes, as Sanjay sir has said, like this is important to look at for the target sign, typical target which is seen. And most importantly, like sometimes we have some lead points why this intussusception is happening. In 90% of the cases, it is idiopathic, but in some children, there may be, like as sir has said, appendix may be inflamed, and that is the cause of the intussusception. Sometimes there could be leiomyoma, sometimes there could be Hodgkin's lymphoma. So all these factors are also ruled out by the sonography. So sonography is very, very important tool here. So Sanjay sir, in Latur, what you do for this intussusception?
Now, since last 8 to 10 years, I always tried hydrostatic reduction, but there is a strict criteria for the hydrostatic reduction. Patient should come very early on day 1 or maximum day 2 of the symptoms. That is the first and foremost criteria. Secondly, patient should not have a distension of abdomen. The visible loops or visible peristalsis should not be there. Patient should not have a bilious vomiting for that purpose. And third and foremost, patient should be ideally fit, not very sick, severely dehydrated, or electrolyte imbalance. These all the cases are ideal. My Latur colleagues are very brilliant and genius. They always send the patient to us in a very most critical period, say within 6 to 12 months, 12 hours of symptoms. I remember that I have not done a single exploratory laparotomy for the intussusception in last 8 to 10 years. Always
Yes,
I prefer barium enema reduction. And big thanks to my senior pediatrics colleagues and my dear colleagues also.
Yes, that's a very good point. Even I haven't done anything in last 5 or 7 years since I'm back in India. The thing is, like what Sanjay sir has told, I would like to little bit, like go against that. In our institution, we give trial to all the children, irrespective of their status, irrespective of their, whether they are stable or not stable. Of course, if the child is not stable, first of all, you make them stable and then take them. So highest number of reductions which I have done is 7 times in a child. Of course, that was the institution, there is no money issues and everything is manageable. But I understand, sir, in private setup, it's a different ball game altogether. So hydrostatic reduction is the commonest thing which has been done now all over the world. In India, majority of us are doing ultrasonography guided. If you go to different parts of the world, they may be doing, like air enema. So they just push the air and under the fluoroscopy, they check it. So now here we are using the fluoroscopy. Fluoroscopy itself has the radiation. Most of the fluoroscopy machines in India, they are not meant for the children, period. So they are giving, 6 or 8 times of the radiation. So try to avoid that. But yes, that's why my main question was very specific to sir, what he does in Latur. So local practice is very important for us. So the locally and the look at the patient, how the patient is looking and how the parents are also. Because whenever we do hydrostatic, there is a down part that it may recur. It may not be complete reduction. So parents has to be aware about it. So I have mentioned also other things which can be done. Earlier we used to do barium minima and laparoscopy as well as open reduction. There are still many centers who are doing the laparoscopy or local reduction as a primary. But yes, it is of course a surgery and complete anesthesia and all complications you have to expect and accept also. So this is how we do the hydrostatic reduction. Sanjay sir, can you please explain it again?
I usually prefer barium minima reduction because our sonologist is not so confirmed and more guidance because of intussusception by the sonography guided.
Yes, that means one more thing.
Therefore, I prefer
barium. All reductions are dependent on the radiologist. So availability of the radiologist is also very important. Even in best of the centers in the world, you may not get a radiologist in the middle of the night. So I understand.
Major disadvantage of the barium minima reduction, if it perforates, it will have a dreadful barium perforative peritonitis. And I have come across one patient of barium perforative peritonitis on the radiology suite itself. And patient was very VIP. You will not believe I have took the patient within 7 minutes for the exploratory laparotomy. And patient I have saved. There are no adhesions, no complication, nothing. That is the only one complication since last 10 years. And secondly, there are 10 to 15 patients, they have got a recurrence for 3 to 4 times. I have to reduce it 3 to 4 times, then it has a failure of the reduction. Then I again go with the laparoscopy. Laparoscopy has got added advantage that these patients are fine, there are no recurrence.
So this is what we do here. We put a parectal large Foley's catheter and we infuse lot of saline. So if you can make it a little bit warm saline, that helps in the reduction because of the reducing the edema and everything. And then if the sonologist is there, on table you get the confirmation, okay, it has been reduced. If you are doing fluoroscopy, then you have to see the air or the barium minima, which is going inside the small intestine across the IC junction. So that is the end point of the procedure. So again, as I mentioned, this is a choice which is based on the local availability or the local practice. And yes, how will you counsel the family when you take these children for the hydrostatic reduction?
Barium minima reduction will take only 15 to 20 minutes. But counseling, I took more than 1 hour. That is the main thing, what I do. Because the chances of recurrence of the reduction, as well as complications of the reductions, or second day, third day, again we have to put the patient for laparotomy or laparoscopy. Therefore, counseling is very important in cases of reduction.
Yes, so in our setup, where parents have to pay out of their pocket, and we rarely get the insurance, better to talk to the family about this. That, okay, this is what we are doing, but this is not the 100% perfect method. Maybe 80 to 90% chance that this will get reduced. Otherwise, again, there is a chance that this will recur also. So talk to the family about it and let them take the part in the decision of their child's, management. So that is a proper way so that we can be very, very fair with them. And yes, recurrence, whether we do any procedure, there is a chance of recurrence. The decreased chances with the laparoscopy and the open procedure. So, now next case scenario, here Dr. Shivaji will like to, so this is a 4-week-old first-born male child and has a non-bilious vomiting. So can anybody just tell based on this single line what we are looking at here? Yes, so either called as CHPS or IHPS. So for insurance purposes, we are not using the word congenital now. Otherwise, they will just outright reject it. So we are labeled, it is infantile now. So just, like a corporate gimmicks, you can say. So no antenatal issues. And so what is your examination? When you examine this child, what you will look for?
First, pacify the child with pacifier and calm the child, followed by abdominal examination. Usually you will palpate olive or mass just below the mid-clavicular line, below the liver, just below it, clinically. And after that, if you are not able to palpate, history is suggestive of findings which are favor of IHPS, and I will proceed with USG. abdomen, EVG of the abdomen, which will tell me whether the stomach is dilated, along with the length of the channel, pyloric channel, and thickness of the channel.
So any one of you who is managing intensive care unit, can you just tell how we'll manage the electrolyte in these children?
Hello?
Because yes, it's a classical, like hypocalemic,
Yes,
hypochloremic
Jamir,
metabolic
In
alkalosis.
symptoms, I would like to add one more thing. When the mother still दह्यासारखी उलटी करते आणि बाळाचं वजन वाढत नाही, that itself indicate it is a CHPS.
Yes. So any one of you can answer, like what are the electrolytes or what we have to do, because this is not a surgical emergency anymore. This is a medical emergency. The child has to be stabilized. His electrolytes have to be in the normal range before we take the children for surgery. Otherwise, child will be okay. The result can be catastrophic also. So anyway, we do all CBC, serum electrolytes, particularly here we are looking at the potassium and the chloride. And of course, get a ABG or VBG and try to find out what is the pH and bicarbonate. So bicarbonate is very, very important in the literature. Now there are so much evidence that, like the bicarbonate is very low in this, high in this patient. The postoperative apnea incidence is very high in the range of 10 to 20%. So that's why we try to correct the electrolytes. So what will be the sonography findings? What you are looking in the sonography?
Sonographic findings usually channel length, sir, which will be more than, usually more than 16 mm, means 1.6 centimeter, and thickness of the pyloric muscle, which will usually be more than 3 millimeter.
Okay, as Sanjay sir just told me, like 4 into 4, so remain 4 चौक 16.
4 चौक 16 हे लक्षात ठेवायचं, रेडिओलॉजिस्टला पण ते सांगायचं बघायला. 4 millimeter length and 16
4 millimeter thickness.
length of the canal.
Yes, so this is again radiological diagnosis, and occasionally we can get some cases with the pyloric spasm also. So that is something which is happening more commonly in India, difficult to document and see the literature. But in pyloric spasm, this finding won't be there. So thickness won't be more, it will be just a spasm, because that doesn't need a surgery. That can be managed just conservatively without doing anything. So we have to differentiate these two things. So how will you proceed, and when will you take the child for surgery?
I'll proceed with the stabilization of the child basically first. Electrolytes plus VBG. If criteria, it's like bicarb. Basically, it depends mostly when to take the child for surgery. Bicarb, 3 values are important: less than 25, 26 to 35, and more than 35. Ideal patient to take up for a surgery is value of 26 to 30.
20 to 26.
26 to 30 milliequivalents. Then we can take up the child for the surgery. If we go ahead with deranged bicarb and electrolyte levels, then we may land up in postoperative apnea and postoperative ventilation also for the child.
Yes, so there is a dictum that which says, if you don't operate a CHPS or IHPS child, they don't die. But if you do surgery in a wrong time, when the electrolytes are not normal, they will more likely to die in the post-op. So we have to be very, very careful about it. So this is just a basic, basic algorithm which you can follow, infant with a projectile vomiting, if palpable mass or olive is there. Most important part is again the rehydration or the correction of the electrolytes. Without that, we are not going to go ahead. And of course, now what surgery you do in Latur?
I usually do open, but sir does laparoscopic also, pyloromyotomy.
So any particular criteria where you like to do the open surgery and not the laparoscopy or something like that?
When the patient is sick, severely dehydrated, and cardiac wise patient is not stable, then I always prefer Ramdas open pyloromyotomy. And secondly, I have a habit, after the anesthesia, I always used to palpate the pylorus. One case I remember, Jamir, that radiologist given a CHPA diagnosis. On operation table, I give anesthesia, intubate the patient, there was no palpable lump.
Yes, that.
Then I again revert it, counsel the patient. Patient was the relative of Dr. P.K. Jadhav with the anesthetist over the Latur. He was working in the Planet ICU. The patient relative were angry, why you are given the anesthesia and why you are again not doing the surgery. But I tell them, and again I do the sonography myself with the help of the pediatrics radiologist colleague. It doesn't to CHPS, it was a case of GR. And in selected cases, when the patient is fit, patient is not sick, I do laparoscopic pyloromyotomy. Care for the laparoscopic pyloromyotomy is that we should be very careful not to open the mucosa. Otherwise, the chances of perforation of duodenal mucosal injuries are very high in case of laparoscopy.
I think Sanjay sir has his next talk on the laparoscopy. He will talk more about it. But yes, this is very simple technique, and you can see, this surgery is done within literally skin to skin within 13 to 14 minutes. And the results are very good. There was a big trial in UK where they abandoned the trial in between because the results of the laparoscopy were far, far better than the open surgery. And yes, there are some institutions where they don't do the laparoscopy when the children are sick or they come very sick. But currently in my practice, I do all the patients, I give laparoscopy, and so far we have been very, very successful. Yes, that's a good question. So atropine has some role. There is a big paper from Japan where they have treated 33 neonates or the infants with the atropine. But sir, believe me or not, this atropine was given for 6 months.
Major controversy, the duration I have treated with the help
Correct.
of atropine in Sion Hospital. And the second is of side effects of atropine.
And then these are the children, what you are telling, yes, sometimes we can think about it. If the child has a very bad congenital heart disease, they are not fit to go for anesthesia.
And we have got a good experience of atropine in incomplete myotomy.
So, as of now, there is no role, sir. But yes, in very, very selected cases, maybe you can think about it.
Yes, always follow-up is good. Unless the surgeon is confirmed about the diagnosis and findings and the patient is losing weight, then only we should interfere. Otherwise, if the patient is having weight gain, then we should really wait. Or we can do a contrast study also. Upper GI contrast study will give exact idea of how much is the contrast agent is retained in the stomach and how much is going in the distal part of the first part of the duodenum. In doubtful cases, we go for upper GI contrast study.
The best way is to assess the child as a whole. Look at what your clinical findings, look at your investigations, and then try to correlate that with the radiologist. Now, as I told you, radiology is very, very observer dependent. So suppose there are 3 radiologists, somebody may say it is 16 millimeters, somebody may say it is 12. So if you have a doubt, wait for another 24 hours, again redo it. Or you can send it to somebody else and just check it, whether they are missing something here. Because as a clinician, you are far sure that this diagnosis is IHPS.
Namdev, in selected cases, we can change the radiologist also.
So, what are the post-op complications, Dr. Shivaji?
Excuse me, sir. Sir, time constraints.
Oh, okay. We'll finish it up.
Pyloromyotomy is really very nice surgery. I don't come across any complications really. In expert hand, we can have an incomplete pyloromyotomy or sometime perforation, but they are extremely rare with the help of pediatrics colleagues.
Okay, if everybody is okay, I'll just finish 2 more scenarios. These are just, like 1 minute. Are you okay? Okay, I'll just finish fast then, because one of this is given by Dr. Sabde, so he was very specific about it. So this is a newborn which is having bilious emesis, no other symptoms or signs. So how will you proceed, Sanjay sir?
Bilious omitting in a neonate and children is always 100% surgical unless proved otherwise. In these all patients, we should always do a X-ray and contrast study, upper GI contrast study. In this X-ray, we can see DJ loop or DJ junction is on the right side of the spine, and the dilated stomach and dilated duodenum. It goes in favor of malrotation or duodenal obstruction. Sometimes color Doppler maybe see the reverse position of SMA and SMV.
Whirlpool sign. So this is just a pathophysiology, and then...
And for the malrotation, it is really a dreadful emergency. Pediatric surgeon should awake in the midnight and go for the surgery, because the chances of waiting and losing the whole of the bowel is very high. If we wait, we can have a gangrene of whole of the small bowel.
So this is one of my patients where, they waited for longer time, almost 48 hours. And when we explored, this is the finding. So this patient is like there is nothing we can do at present in our current practice. It is very difficult. So whenever you think about malrotation, involve the pediatric surgeon as early as possible, take them to the surgery as early as possible, because this is like a super medical or surgical emergency. So last one is again a common thing. This is a 4-year-old boy with a fever, cough, and difficulty in respiration. So this is his chest X-ray. So looking at the chest X-ray, you can make it out what is happening. Dr. Santosh, can you just explain and read
for a
this?
pediatrician, this is a very common gastroenteritis and respiratory infection. This is like a bread and butter. So many 70% of OPD is like a cough, cold, fever, and we see these complications day in, day out. This is like a this X-ray showing like a right-sided pneumonia with some effusions around it, and some on upper lobe, some emphysematous bullae could be because of maybe a staphylococcal, probably.
Yes. So in this patient, how will you proceed then?
Actually, most important is initial stage when there is a pneumonia with pneumonic effusion. We can just give a maybe appropriate IV antibiotics and just do a sonography to see the collections. And most sensitive modality is a sonography, which will tell us the loculations. If loculations are not there, then we can tap, we can just put the ICD and give the antibiotics. But if loculations are there, then we need to put a ICD along with some streptokinase or urokinase. That is the most important, which is a newer emerging modalities and which has a very good results.
So, just the take-home message here in this particular presentation is just don't put the chest tube only. So there are so many things which are associated with just putting the chest tube. Avoid that, and if you can add some fibrinolytic therapy, which is helpful in almost 50% to 60% of the patients, you can do that. And ultimately, many children may need VATS also. So only chest tube has some issues and problems, but yes, it is easily available, can be done, and so pleural tap. So what do you think, what you will do in your practice?
At present, we are doing like chest tube drainage, and with chest tube drainage, if it is not improving, then we are going for VATS or decortication, depending
so
upon.
Roughly how many percentage of the patient they respond to only chest tube?
Actually, maybe majority of patients at the end, they need surgery, either VATS or decortication. It is like a whole of pleural cavity filled with pus, and that's the reason like older recommendation used to give around 4 to 8 weeks of antibiotic. But if we follow chest tube drainage with streptokinase, urokinase, we may be able to go away without long duration of antibiotics and maybe a primary VATS. Then the duration of antibiotics also will come down. It is like maybe a boil where you have a external opening from the skin where everything pus you can remove out. But inside the pleura there is no place. So each and every small quantity of pus or pus flakes you should remove it out. Then only there will be complete eradications and you can save the organ.
Okay. Okay. Thank you very much. Sorry for the delay.
So please don't be.
Yes.
Urokinase is better at this time. Streptokinase has its own issues, mainly the anaphylactic reactions.
Extra mic. Extra mic.
Yes.
After putting the tube, we have availability of streptokinase or urokinase, but I found probably just 10 or 20% will require VATS. Maybe
yes, overall chances of needing any kind of intervention, they decrease.
Yeah.
Whether it's an open decortication or VATS, whatever. Yes, sir.
Where to do VATS and corticotomy? Because early intervention with the VATS is very good result.
Yes, that is what is called as a primary VATS nowadays. So primary VATS is without putting the chest tube. You assess based on the sonography, how the loculations are looking. They are very thick. Look at the child's condition and straightforward go for the primary VATS, where we just take the intervention with the help of the 2 small ports and they do what we are showing here. So that is the best results currently.
For stage 1, stage 2, VATS is the prime role, and stage 3, open decortication.
By the time patient come, it's always very late. When it comes to pediatrician, then treatment for
the
pneumonia.
time lag we have to assess also. When we do any kind of management, we have to think about the time.
And even if you go for a primary VATS, what sir was telling, it will decrease number of days of antibiotics.
Correct.
It's more of a toxemia. So ultimately, the duration of antibiotic comes down when you are treating staph.
Yes.
So at
Following
the end of the day,
primary VATS, we are discharging the child within 3 days now.
even if you discharge,
So that's a significant difference.
I think in Indian scenario, what was the follow-up of those kids? They will come to you with febrile illness subsequently after 2 weeks or 7 days also. I think it needs to be studied further. Primary VATS as a primary intervention for empyema, I think we need to follow that.
Yes, sir.
Sorry, I need to intervene, but any questions to any speakers or moderators, kindly consult them. Personally, I know they are very knowledgeable and they really will help everyone, but we have time constraints. It was an excellent session, sir, and precise briefing of all emergent pediatric surgical conditions by all the experts. We all are even more fresh now. I would now request Dr. Rajiv Kulkarni, sir, and Dr. Subhot Subhani, sir, to felicitate our panelists. And before that, I would like to request all the panelists to kindly felicitate our moderator, sir, Dr. Jamir Arlikar, sir, for such a wonderful session.